All right, let's conquer fetal monitoring. We're going to try to do fetal monitoring made simple. Look through some objectives here, identify the purposes of fetal surveillance. Why do we need to monitor women in labor? Explain the normal mechanisms and the pathologic mechanisms that influence that heart rate, and identify advantages and limitations of auscultating and palpation versus the electronic recording. Explain the types of equipment used. We'll talk about the fetal monitor, and then we're going to describe the interpretation to include all of these areas. You're going to become an expert on fetal monitoring by the end of this. Well, maybe not an expert, but it'll make more sense. Explain the methods used in addition to external fetal monitoring to judge the fetal well-being. Describe the appropriate nursing responses when there is a non-reassuring fetal heart rate pattern. What do you as a nurse need to do? And then use the nursing process to plan care for the woman having fetal monitoring, and then how to document it. All right, uterine activity, we'll start there. It consists of 3 measurements: the frequency of the contractions, the duration, how long the contractions are lasting, and intensity, how strong each contraction is. External monitoring must include palpation of the uterus and not just reliance on the monitor strip, because that external tool cannot measure strength. And here's one of my drawings again. External monitoring, there's the uterus and the baby. If you guys are tired of this, I'm sorry, but it's the only way I know how to do this. Okay. Whoops, the arm got out of the uterus. All right, so the monitor is going to go up here on the mom's abdomen, up right under her at the top of the fundus, wherever it's the firmest spot. So that's where the external monitor will be. And as you can see, it's going to be able to measure how often they're having a contraction and how long it's lasting, but you cannot tell how strong it is, because if this mother is really skinny, she's going to look like she has really strong contractions. But then if you have a mother who's got a lot of adipose tissue and there's all this extra stuff on top, and that monitor toco is, whoops, I'm sorry, I don't mean to do that, my arm. Anyway, and the toco's here. Do you see this extra space between that and the baby's baby's part? It's going to not be as accurate. It won't be accurate at all. So that's why we need to palpate the uterus to see how strong they are, because that's how we measure that on the external. Internal monitoring is different, which we will talk about when we get to internal monitoring. When we evaluate those contractions, we're talking about how frequent they are, and by measuring from the beginning of one contraction to the beginning of the next, or measuring from the peak of the contraction to the peak of the next if they are uniform in shape. And adequate labor, I want you to remember this, adequate, not true labor. That's different. True labor is cervical dilatation, right? Don't confuse the two. Adequate labor means that uterus is contracting at least every 2 to 3 minutes. That is going to be one of the requirements to have adequate labor. The duration of the contraction is measured from the beginning of the contraction to the end of the contraction, and that adequate duration is 30 to 60 seconds. So think about it as 60 seconds. It's got to last long enough to be considered adequate. The intensity is measured at the peak or acne phase of the contraction, and it is not reliable on that external because of all the variables between, the mom's subcutaneous tissue, body fat, etc. In order to properly evaluate intensity, you have to have an internal pressure transducer on, and that's put in by the provider, and I'll explain that in a minute. The external method of monitoring requires palpation for appropriate assessment, and that is kind of subjective. Yes, we can, if something's rock hard, it's rock hard, but it's hard to properly assess someone who's obese. It is. Adequate labor for intensity requires the contractions to meet this much millimeters of pressure. And for ease in remembering, just think of 50, 50, 50, 45 seconds, 45 millimeters. You get the idea. It's got to be a strength that is strong enough to cause dilatation. Additionally, the resting tone. The uterus has a tone even when it's not contracting, and that tone is important to make sure that we don't have a high intensity tone always on that fetal the baby. So the acceptable resting tone is 5 to 15 millimeters of pressure. Don't panic. This will make sense in a minute or two. When we're palpating the uterine activity, go ahead and touch your nose. When you push the tip of your nose, it's considered a mild intensity contraction. Now touch your chin. You feel how that's a little stronger, a little firmer? That is considered a moderate. And then your forehead, very strong contraction. That's kind of some guidelines for palpating the strength of a contraction. Adequate labor. Adequate labor is effective uterine activity that has coordinated contractions that are strong enough and numerous enough to dilate the cervix and propel the fetus through the bony pelvis. In short, the adequate labor is what's going to dilate and deliver a patient, okay? It varies from woman to woman. I have had patients who contract every 5 minutes, and they do fine, they deliver. I've had patients that contracted every 2 minutes and never could deliver. So this is going to be different from woman to woman, but there is a guideline as what's considered adequate labor. To be considered an adequate labor pattern, contractions must occur every 2 to 3 minutes, last about 45 to 60 seconds, and reach that intensity of 45 to 50 millimeters of pressure. All right. The reason this is important to know is if someone is meeting this criteria in labor, whether it's natural labor going on their own or we are causing induced labor, if they reach this criteria and they are not dilating, they're not going to deliver. Bottom line. In order to claim dysfunctional or inadequate labor prior to doing a C-section, these 3 parameters must be met. That's going to be our criteria. If she's only contracting every 5 minutes, she's not in adequate labor unless she's dilating, right? Because that varies from woman to woman. I've had someone do that. But in general, if they're not contracting every 2 to 3 minutes and they're not dilating, that's not adequate labor. We need to increase the Pitocin or induce them if they're not on Pitocin or augment their labor to get to this minimum criteria to give that uterus and baby the best chance of a vaginal delivery as possible. Okay? If these 3 criteria are met and the baby's not coming after a few hours, done. There's no point in continuing on. Now, again, true labor is different than adequate labor. Do not confuse them. True labor means the cervix is dilating. Adequate labor is developed as a way to assess whether or not the labor is adequate enough to dilate the woman who is in labor. Other terminology that you may hear in the labor and delivery unit would be what's called arrest of dilatation. That's times dilatation is arrested anytime it stops. The protracted active phase of labor, if you remember the chart that we talked about in interpartum, that active phase is 4 to 7 centimeters. If that protracted active phase, if they stay stuck at that and don't progress, that's called protracted active phase. Arrest of descent, she's gotten to 10 centimeters, she's pushing, but the baby doesn't come down. That's another term you may hear. The uterine activity, it is normal to have less than or equal to 5 contractions in 10 minutes, averaged over a 30-minute window. We will go through some slides on this, so don't panic. Just make some notes. If we are seeing in a 10-minute window more than 5 contractions in that 10 minutes, she has what's called tachysystole. She's contracting too often. Remember that for every minute the uterus is tight in a contraction, there has to be a minute of relaxation for that fetus to recover. And with tachysystole, with more than 5 contractions in 10 minutes, that baby is not getting recovery time. Tachysystole should always be qualified by any effects on the fetal heart rate. So we're going to talk about them as well, whether there are decelerations of the fetal heart rate. So we don't evaluate them all on their own. We always have to look at the effect on the fetal heart rate. So now you're going to see the graph, the chart that we look at in the labor and delivery ward, and hopefully help you better understand this. As I said, in order to determine how often a contraction is happening, how frequent they are, you look from the beginning of one to the beginning of the next. All right. Do you see this heavier black line here? They're a little hard to see, but I think you can. Each of these is a minute apart. Every square is 10 seconds. 60 seconds. So these heavier lines are a minute apart. So the way that you would count these, if you see this is the third line in from the heavy line. See that? There's a heavy line. It's a third line in. So the third line in here is 1. Third line in 2. Third line in 3, third line in 4. These are every 4 minutes. When I say every third line in, do you see that? 1, 2, 3. That's where that starts. 1, 2, 3. Oops, I went too far. 2, 3. So that's where I'm counting from here to here to here to here. 1, 2, 3, and then one more. 4 minutes apart. Can you see that? The other way I mentioned, you could do it from the peak to a peak. All right, see the peaks? So let's count these. Oh, this happens right on the heavy line. See that? So this makes it a little easier. From here to here is 1 minute, 2 minutes, 3 minutes, and a little bit. So when I say a little bit, we are not so picky that you have to go 3 minutes and 10 seconds. But you'll say every 3 minutes here. This one, we're going to pretend that keeps drawing. Let's see how far apart this one is. So the peak is here. So 1, 2, 3, and probably 4 minutes. Just like the same information we got going from beginning to beginning, we got going peak to peak. Okay, so she's contracting every 3 to 4 minutes. Now let's look at how long the contractions are lasting. Now that you know that each square is 10 seconds, you can determine that. So it starts here and ends here. So how many seconds is that? 10, 20, 30, 40, 50, about a minute. Again, you could rough it down, about a minute. This one we have to kind of make up because we don't have the beginning, but we're going to say 1, 2, 3, 4, 5, 6, right along there, about a minute. So they're lasting about a minute. Now that you know the definition of adequate labor is contracting every 2 to 3 minutes and they're lasting about a minute, is this adequate labor? No, because they're not contracting every 2 to 3 minutes. They're lasting long enough, but they're not happening often enough. Okay, so that is a nice regular pattern though. That'll get closer together and she'll probably deliver. Now down here, let's see what we're doing down here. We've got the peak here and okay. Develop a pattern to your report to a physician. You'd want to say she's contracting every so many minutes, lasting how long, and how strong they are. Kind of develop that pattern. So I always look first for how often are they happening. So it's peak to here to a peak here. You can already tell they're a little bit different in intensity just by looking. So from here to here is about a minute. Then from this peak to this is a little bit over a minute, right? But from here to there is 1, 2, 3 minutes. So she's contracting every 1 to 3 minutes. This is called coupling. We got 2 contractions. The second one's a little less intense, and they kind of keep coupling every so many minutes. Let's see how long every minute they go from here. 1, 2, 3. Every 4 minutes she gets a coupling like that. This is not functional. This is a uterus that needs to be augmented with Pitocin to kind of break this pattern up. This is just going to be annoying. Down here is tripling, kind of the same concept, but they're 3, pause, 3, pause. Again, this is dysfunctional and needs to be stopped, whether it be by hydration with IV fluids or given breathing, depends on the situation. But this needs to be corrected, and you could do that with Pitocin augmentation. Tachysystole, that is another word for hypertonic uterus. Write that word down as well. Hypertonic, too much tone in the uterus. Tachysystole is the new term for that. They keep changing terms. I don't know why, but nevertheless. So tachysystole is where it's happening. How often is she contracting? There's one there, there's one there, there's one there, there's one there. It's almost tripling. You can almost see a tripling, but it's happening. Boom, boom, boom. That baby does not have recovery time, okay? Same with this one. Again, start, 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 start. They're happening every 1 minute, 1.5 minutes, 1 minute, 1.5, I mean. So let's do that. So this is from here to here is about a minute. From here to over here is about 1.5 minutes. From here to here is about 1.5 minutes, and from here to here is 2 minutes. So these in here are too many. That's tachysystole. This one's okay, but this baby does not have that minute of recovery time in there. So that's tachysystole. These are some interesting things just to look at. This is normal, nice curve. Respirations, you see the jaggedy, that's mama breathing. Pushing, you'll see it looks like the city of New York. Push, 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 push. This is vomiting or seizures, but vomiting, you'll see that quite frequently. Baby kicking. So those are just some interesting things to see, to notice, because it's you'll see these a lot, especially when we're sitting out at the nurse's station. We see something like this. Oh, she's pushing in room 3. Okay, or she's throwing up. We can see that too. So now let's evaluate the fetal response to the contractions. The first thing to understand with the fetal response is the fetal's blood supply and what affects its ability to have the adequate oxygenation and tolerate contractions. This is a picture of a cotyledon of a placenta. Okay, the placenta is made up of about 16 to 18 cotyledons, which are small clumps, which have these dense, they look like this. It's not just a smooth surface. And I'm going to tell you why in a second, but you see, it's not just smooth like that. It has all these cul-de-sacs, right? These cul-de-sacs are there because picture the blood going through there. As the blood goes through this area, it has all this area additional for oxygen transport. All right? That's why they have all cul-de-sacs, so that the blood has more surface area to have oxygen transport. So that's really cool. If this was just a straight, smooth surface, how much less surface would there be for oxygen transport? A lot less. So that's the basic thing I'd like you to know about that placenta and the transportation of oxygen into the fetal circulation. This is a great schematic of the placenta and the blood flow exchange. Do you see this little tiny area here? How much down here, how much blood gets transported through that area? There's a lot of capillaries in that area. The other thing to notice, look at the umbilical vein and arteries. How many veins are there? One, and the vein is red. The vein is the red blood. It's opposite the adult circulation. The arteries have the blue blood in them, the non-oxygenated blood, and the umbilical vein is the oxygenated blood in this system. If you are ever asked how many arteries and veins are in the umbilical cord, do you see the blue, and then the red? There's 2 arteries, 1 vein, and just kind of think of that as 2 AV. 2 AV. If you memorize that, you'll know there's 2 arteries, 1 vein, 2 AV. Okay, because it's the umbilical vein is what is taking blood to the baby, and the arteries are removing it out. That's why the oxygen is different on there. It's opposite of the adult. What happens to those arteries during labor when contractions are occurring? They're getting squeezed, right? And fetal oxygen reserve is enough for about 1 to 2 minutes. So that's why I've mentioned that for every minute of tightening of a uterus, there needs to be at least a minute of release and relax time for that baby to recover. Anything less, you're stressing the baby too much. These are some factors that may potentially decrease utero-placental perfusion, and if you think about them, they make sense, right? Maternal hypotension, what happens with hypotension? Okay, the problem is low blood flow. The mom's maybe bleeding, has some trauma. If there's epidural, can cause this as a result of medication. Side effects of super dilating her blood vessels. You get hypotension, you're going to have less blood going through the placenta and therefore to the baby. Hypertension is the same reaction or the same result, but different mechanism. That's because the arteries are too tight, and that's with your hypertensives. Some of the medications, when I say medications, they're cocaine, meth, or stress. If you have too tightly constricted blood vessels, you interfere also with blood flow through that placenta. The placenta itself may have issues if it's getting too post-mature. Remember, after about 42 weeks, it starts to get aging and calcifications and starts to harden. So that can cause decrease in oxygen exchange. The previa, which we mentioned, previa is where the placenta lies low and covers the cervical opening sometimes. That will interfere with oxygen exchange. If this placenta is really small, that can be due to nutritional deficit or drug use or smoking. Abruption, the placenta rips off. Of course, that's going to take away blood from the baby. Diabetes does have a side effect of causing interference with blood flow through the placenta, and then those calcifications, smoking already mentioned, and infection, of course, placental infection. A decrease in the mom's hemoglobin, anything that makes her at risk for low oxygen is going to make the baby at risk for low oxygen. So whether it be due to unable to, she's having rapid breathing, that actually will happen if they get hyperventilating. Of course, cardiopulmonary disease would affect that, and severe anemia. So that's another reason we do lab work on admission to labor and delivery. Tachysystole, as you've just learned, is contracting every minute and not getting enough time to relax, and that may be due to oxytocin, too much. She's maybe doing it her own body, putting out too much oxytocin, or it could be our own pitocin. We need to back off on what we're doing with our pitocin. And of course, that placental abruption that can happen as a result of this uterus contracting too much. There are some other high-risk conditions, but just remember, anything that's going to affect the mom's ability to have good blood flow and oxygen is going to affect the fetus. Cord compression causes may happen if there's a knot in the cord, or if it's tangled or compressed. Of course, that's going to interfere with blood flow through the cord. It's going to cause problems with the blood flow and oxygenation. And then the fetal factors. If the fetus has fetal anemia or hypotension, any of its own cardiac deficits, that will cause decreased oxygenation also in the fetus. Risk factors for initiation. Who needs to be monitored? Well, in this day and age of legality, everybody's going to get monitored pretty much, but there are some that really have to be monitored, and the lists are here that you can look at. Anything in the mom's history that gives us an increased concern: prior loss, C-sections, infections, chronic diseases, the hypertension and diabetes, hematologic problems, they have low platelets perhaps, drug use, psychosocial stress, domestic violence. All those, of course, are going to put this fetus at risk, so she should definitely be monitored when in labor. And then antepartum, again, the high blood pressure, diabetes. We've kind of mentioned all these different times, but these are the people that really should be put on the monitor. Intrapartum, if they've ruptured membranes before labor, we want to check for that cord, make sure it doesn't become a problem, right? Prolonged rupture of membranes, because of infection, we want to be careful to observe them. And then the blood pressure, hypertonic or again, tachysystole, failure to progress. Let's make sure the baby's tolerating this non-functional labor. So any of these, and then the placenta, the fetus, of course, meconium stained amniotic fluid, that means the baby had a bowel movement, drop of oxygen. We do need to monitor those. If they're breech or foot-length presentation, prolapse cord, abruption. So there are a lot of reasons that they really need to be on the monitor. The reason we do electronic fetal monitoring is to assess this utero-placental physiology. And it serves as an indicator of fetal oxygenation. Understand, this is a little patient we can't see. We don't have a little window in the abdomen where we can watch him. So this is our window, is through that monitor. And there are two modes of monitoring. There's internal and external, and we use them to provide us information on how the baby is tolerating the stress it's under. The external monitor, when you're in labor and delivery, this is a really old one, but you'll see some version of this monitor there. And the external has that tocotransducer ultrasound to monitor contractions. And then the internal would be a fetal scalp electrode, is what that stands for. And you'll hear the little screw. It's not a screw. Well, it's got that screw form to it, but it just goes under the very superficial skin. We try not to use an internal monitor on the baby if we don't have to, but some babies need that internal method of monitoring. And understand that in order to do the internal, either one of these, they have to be ruptured membranes. We can't do it with water bag intact because you can't get to them. So in order to have an internal fetal scalp electrode, the water bag has to be ruptured. And the scalp lead is what that's called, put on. And then the IUPC is a pressure gauge that goes around the fetal body. And these are used to give us really accurate information when we have that really high risk patient. We use this fetal scalp electrode a lot more commonly than the intrauterine pressure catheter, to be honest. They're both used, but I would say the internal. If they're dilating, we don't need the IUPC, the intrauterine pressure catheter, because if they're dilating, we know that they're having enough contractions. We use that if they're not dilating. We got to figure out why. Okay, here are the fetal scalp electrode. All right, here's the red and green coil. You see that there? That is the internal fetal electrode. There's that it's not a screw, but it goes just inside the surface of the head. See that? Looks like a little screw, but it doesn't screw in, okay? Everybody kind of worries about that. It doesn't. And then the IUPC, intrauterine pressure catheter, that is this right here going in and goes around the baby's head and kind of goes down inside between the baby and the uterine wall. And that's got a little pressure gauge on the end of it that picks up pressure. and records it very specifically on the fetal monitor strip. This is fetal spiral electrode placement, so the FSE placement. You can even do them on a breech baby. You just got to hit the butt. This is more than you need to know, but just that's how it's put in, and that's why you have to be ruptured membranes, right? The place to put the FSE, you want to avoid the fontanelles. You don't want them in this area, so we hit over bone, okay, or the buttocks. And then the IUPC, it just gets guided around. And again, this is what the providers do. Nurses do not put these in. Leopold's, I mentioned Leopold's in the interpartum assessment. So this is where you're going to see this again. And hopefully you looked them up in your book. But you can see the first thing there, the first thing I do, it says the third maneuver is the head. The first maneuver is to palpate what's in the fundus. I always start with the head. It doesn't matter first, second, third, or fourth. What matters is doing the 4 maneuvers to figure out where how this baby is laying. So determine what's up in the fundus, and then you see if you can find where the backbone is, and it will feel firm. Like over here where the feet and hands are, it's not going to have a solid feel. You know, if you're palpating around the back, you're going to feel that spine feels like a solid curvature area. Then you feel down what's in the pelvis, and this is the nice fetal head, and you can kind of, this person would, with their hands here, would kind of shake the head. You can feel it bob back and forth. And then the final one is to feel both the back and the tummy, the back and the baby's abdomen area to determine if the head, which part of the head is it's flexed or not. So mainly what you guys will use this for is to determine where to get fetal heart tones. Okay, so remember, you'll get fetal heart tones towards the baby's back and head. So knowing that, I would be listening right here on the mom for fetal heart tones, and that is the lower left quadrant of her abdomen. If the baby was facing the other way, the heart tones are going to be over here. Okay, so that's one reason that you need to do those. Know the fetal positions and where you'll hear the heart rate. So here's the baby out left. L is left. O is the occiput of the baby. And anterior is the anterior part of mom's pelvis. So the occiput being right here is on mom's left side. Okay, and it's facing, it's a little hard for you to tell, but it's facing towards the front of mom. All right, so where are you going to hear the heart tones? If the head's here and the back's here, you're going to hear them right there. Then we have ROA, right occiput anterior. Okay, so the occiput's here, it's on mama's right, and it again is anterior. You're going to get the heart tones over there. Left occiput posterior. This is a good schematic of this, and I can't even really draw the occiput because it's at the mom's tailbone on both of these, okay? Left means it's a little bit more on the left side. You're going to hear the heart tones a little bit higher than you do. They're a little bit harder to hear because they're behind, but you'll still hear them. And then the right occiput posterior over there. The baby's facing, the occiput's on this side of mom. Here the occiput's on that side of mom, left or right. Now we have the breech, and it's called sacral. They don't say LBA, they say sacrum. They go by the sacrum. Left sacrum is anterior, right sacrum is anterior. So you see the sacrum is down here on mama's left or mama's right, and you're going to get those heart tones towards the back near the head. So do you see how much higher they are? Mom's belly button's probably right about here. All right. So the heart tones are going to be really close to the belly button, mom's belly button. The tracings, you need recorder paper, and the patterns are assessed and interpreted by evaluating 3 parameters, which we will talk about. There's the baseline of the heartbeat, the variability of the heartbeat, and then periodic changes. We will go through these so that I'm sure you will understand them, and if not, listen to it again. This is a typical tracing paper. Look at the numbers here, 240. What's this number? 100? Okay. Which one do you think would be the fetal heart rate side, just looking at the numbers possible? If the highest number possible, okay, fetal heart rate, what's normal for a fetal heart rate? 110 to 160. Let's start there. So that's the normal reading for a fetal heart rate is 110 to 160. So now that you know that, I can't write that 6. Now that you know that, which side do you think, which is the fetal heart rate? Obviously, the one that can give you 110 or 160. These don't go up high enough down here. So this is how that's read. It'll be you'll see heart rate tracing on one of these lines. We'll be doing that in a minute. And then this is the uterine activity. We've already looked at one a little bit, but do you see how this heavy line and this heavy line, they are 1 minute apart. 1, 2, 3, 4, 5, 6, 10 seconds each, 60 seconds. And the same with the baby. I mean, these are 1 minute apart too, just so you know. Contractions with the external, we can tell the frequency and duration. Remember, we must use palpation to determine intensity with the external, and that's not highly accurate. The internal, IUPC, we can tell frequency, duration, intensity, how strong they are, and the resting tone of the contraction. Okay? Yeah. So looking at this, baseline heart rate is usually easier to assess between uterine contractions. So heart rates are going to maybe have a reaction to the uterine contraction, so the best thing is to look in between them to see what it's doing without being stressed. This heart rate is hovering at about this line, right? What number does that line seem to be to you? If you said 140, you'd be right. Okay, now you see there's a variability, up and down, up and down, up and down. That's normal. We have to have that. Your heart rate as you sit there and move or think or blink is doing that as well. So the baby's got really good, this is the variability, which we'll talk more later. We like this. We like this good variability. So we're going to look at the overall, where is it hanging out to determine our baseline. And for this, I would say 140. Okay. Then we look down here, what did we learn about contractions? Peak to peak, start to start. How often are these occurring? You tell me. I'm going to give you a moment to try to assess how often these contractions are occurring, knowing that these are your 1 minute lines. If you said 2 minutes, you'd be correct. All right. How long are they lasting? About a minute. All right. That baseline fetal heart rate is assessed between contractions with no fetal movement noted. The average rate is 110 to 160, and it's measured over about 2 minutes. It's rounded up to 5 beats per minute. We would never say 112. Okay, we wouldn't say 156. Okay, so we do use the 130, 145, 160. And it excludes temporary increases or decreases. We're looking for where is it pretty much hovering. Variations, bradycardia is when the heartbeat baseline is less than 100 beats per minute for at least 10 minutes. And tachycardia, more than 160 beats a minute for at least 10 minutes. So those are brady and tachycardias. The causes of these changes with bradycardia, if there's acute hypoxia, the heart rate's going to slow. Drugs can do that. Cardiac arrhythmias of the baby, heart block, and hypothermia. Tachycardia will happen with maternal fever, fetal infection, low oxygen as well, drugs, hyperthyroid, and then cardiac arrhythmias. But just realize the maternal fever is the most common cause of tachycardia. All right, here's fetal bradycardia. What is the baseline? I'm going to let you tell me first. You tell me, you're not going to tell me, I'm on a video, but you can tell yourself what you think the baseline is. Pretty straightforward. You should have said 80, okay? What is this baseline? Saying about 200, you'd be right. Fetal tachycardia. So now that we've determined fetal baseline, let's look at that variability. I've mentioned that. That's the wiggliness, the fluctuations in the baseline, which is normal, it's good, it's healthy. It means the baby can adapt to its own movements. It results physiologically from a continuous balancing of the sympathetic and parasympathetic branches of the autonomic nervous system, just like ours does. As we move or we just make any changes in what we're doing, our body will accommodate by increasing or decreasing our heart rate to accommodate that. Variability is the most important indicator of fetal well-being. If I have good variability, which I will show you in a minute, if I have adequate variability, I know I have a baby with a good neurological parasympathetic system going on. It's not been impaired. I'm good. We've got time. We can work with that, okay? If my variability goes away for very long, then I'm thinking neurological damage. We're going down a bad path. We don't really talk short-term and long-term variability anymore. So I'm going to just kind of skip this a little bit so we go directly to variability. Okay, so this top one, what does your gut tell you? Is that very wiggly? No, it's almost a ruler line. It's almost a straight line. So that is absent variability. There's none. Okay. This has a little bit of movement. Do you see a little bit of up and down? That's going to be minimal variability. There's a little bit, but ooh, and this baby's probably sleeping. This you will see this frequently once we've given mom a sleeping pill, perhaps the night before labor or induction. The baby will also sleep and settle down like that. So that's not necessarily bad, but we have to have a reason for it being this minimal. This, are you liking that variability? Do you see that baby's ability to change its heart rate based on its own needs? Yes, this is moderate. This is a good one. Moderate variability. It's defined as the minimal variability is defined as the change in the heart rate by 1 to 3 beats per minute. That's it. Moderate is the change in the heart rate by 5 to 10 beats per minute, 5 to 15 perhaps, okay? Then we have this really all over. This is marked, M-A-R-K-E-D, marked variability, and that you almost can't even tell a baseline with these. It's just up and down and up and down and up and down. There's really no hovering anywhere. This is not bad. It just is. It's marked variability, and that probably would settle down and become more moderate. That's what we'd expect. This baby's just moving around a lot, perhaps. Then we have this interesting thing down here, and that is what's called sinusoidal pattern. That's the little alligator, whatever, you know. Why does it remind me of an alligator? But that is a result of either a heart problem with the baby or, more commonly, drug side effect of drugs. Medications the mom has taken might cause that. The variability, the descriptive terms, absent means there's no change. It's that straight line. Whoops, it's a straight line. Shh. Minimal, you saw that. It's less than or equal to 5 beats per minute. It changes, but not a whole lot. Whoops, I'm going too much. It's hard to do this. That's more moderate, guys, seriously. Moderate is 6 to 25 beats per minute. So I said 5 to 15, go up to 25 beats per minute on that. Nice, healthy variability, and marked is greater than 25 beats per minute. And you assess variability on the strip where there are not any accels or decels, which we'll show you. If you include accels and accelerations and decelerations, you won't get a true reflection of variability. So we haven't yet talked about accelerations and decels, but we will. So here's the absent variability. This is minimal, again. This is moderate, again. And this is marked, again. So you should be able to, if you're on a maternal unit, you should be able to look at a strip after kind of wrapping your head around these and go, oh, this baby doing so good. This baby looks really good. I'm seeing a lot. Tell me about this baby. So ask your nurse to help you further understand these if you're fortunate enough to be in labor and delivery. Causes of altered variability will be if it's increased, mild hypoxia, the baby's heart rate's trying to pump more blood to oxygenate itself, and more likely would be fetal stimulation. It's just moving around. Decreased, your extreme prematurity, they don't have that well-developed neurological system yet, so you're going to have decreased variability on preterm babies. Cardiac arrhythmias, hypoxia again, acidosis, drugs, and then fetal sleep. We mentioned that, giving mom an Ambien, the baby will sleep. And these sleep cycles happen even during labor. The baby they could sleep for about 20 to 30 minutes, and then they should wake up and get more active. So you'll see 20 to 30 minute sleep cycles on these babies. It's pretty cool. Okay, so this one is a monitor strip. Let's see, we've got external over here, internal over here. Fetal electrode, IUPC. This is the ultrasound, which is external in the transducer. So look at the difference here. The ultrasound, you're getting some variability there, but this, whoops, I didn't mean to make that blue line, purple line. But this, you see how it's much more definitive. Your internal is going to give you a better reading of that variability. Baseline is easy to tell, it's 140. But the variability will appear greater on an internal because it's picking up every little beat change. Externally, we don't get every little beat change. So externally, we don't get that. Now down here, you're seeing the external monitor showing the contractions. They're with every kind of minute that looks like, yeah, they're every minute here, and they're lasting about a minute. We don't know how strong they are. This is arbitrary. All right. But over here is the internal. So now we can see very specifically that these, yes, are still every minute, just like we saw on the internal, or the external, I mean. But what we additionally see here is it's rising. The baseline is about 5 here. So it goes from the baseline of 5 up to whatever this number is. Looks like 50. I'm seeing 50 over there. So it's going from 5, a resting tone of 5, up to 50. So 50 minus the 5 means this contraction is 45 millimeters of pressure strong. Is that adequate for labor? 45 millimeters of pressure, is that strong enough? And are they frequent enough? Would you determine that these were adequate contractions? Yes, they are. Next, we're going to talk about those periodic changes in the heartbeat that I mentioned. These are temporary, they reoccur from baseline, and they are associated with uterine contractions. We have accelerations, and then we have 3 types of decelerations. We will talk about each one of these. Accelerations are the most common periodic change in the fetal heart rate. To be called an acceleration, that heart rate needs to be, the heartbeat has to increase 15 beats per minute above the baseline, and it must last at least 15 seconds, up to 2 minutes. Prolonged accelerations will last 2 to 10 minutes. An acceleration lasting 10 minutes or more, you basically just changed the baseline. Accelerations are not a sign of distress. They are a very reassuring symptom of fetal well-being and are a very normal response. So accelerations are always good, Always. Always, always, always. Okay? Remember, it has to meet the criteria of increasing 15 beats per minute above the baseline and last long enough to be called an acceleration. Now let's put that into practice, what you've just learned about an acceleration. Looking at this strip at the top, because remember the 240 is going to be your heart rate side. This is just 100. Babies go higher than 100. So looking at the fetal heart rate side, what would you declare the fetal heart rate baseline to be? All right, if you said 140, 135, 140, I would agree with you. It's about a 135, 140. Some people say 135, others 140. They're fine. It's either one is fine. Okay, so good. So now we're going to determine what about the acceleration. It has to raise how many beats per minute above baseline? 15? Yes, let's see if this acceleration does that. Okay. This is where it starts on this line. Each of these is 10 beats a minute in heart rate, right? Each square. So let's see if it goes up at least 15 seconds worth. So 10, 20, 30 beats per minute. Yes, that meets the criteria because it elevates at least 15 beats per minute. The other thing to evaluate is how long does it last? Remember, an acceleration needs to last at least 15 seconds. And remember your lesson, these are each worth 10. So is it lasting 15 seconds? 10, 20, 30. Absolutely. This is an acceleration by definition. Come over here and on your own define whether that, figure out what that acceleration is, if it's meeting the same criteria. And you should say yes. Now you tell me, well, you can't tell me, I'm on video again, but tell yourself, is this an adequate acceleration? Is that an acceleration by definition? First of all, start with your baseline. Remember, what's the baseline? Okay, 130. What's the peak here? Goes up to, looks like 160. From 30 to 60 is 30 beats a minute higher, right? And secondly, is it lasting at least 15 seconds? 10, 20, 30, 40, absolutely. So these are nice accelerations. They're happening right with the contraction. You see down here, we always pay attention to the contraction. And that just means that baby's doing really well. It's tolerating these thrust to it beautifully. It gets squeezed, it says, woo, I'm going to have, woo, my heart rate go higher. Beautiful baby. What would you say about the variability here? I'd say it's kind of minimal, but with this acceleration, that makes it be more moderate because this is actually moderate here. So it looks really good. Early decelerations. We're going to talk about decels now. We've talked about the accelerations, 15 by 15 rule, remember. Decelerations occur only during contractions as the early decelerations occur only during decelerations as the fetal head is compressed. And then they return to the baseline fetal heart rate by the end of the contraction. They are mirror images of the contraction and are not associated with fetal compromise. They're very normal. There's nothing wrong with them. They require no additional interventions. Okay? Earlies are fine. It means the head's moving down. The mechanism of earlies, you get pressure on the fetal head. That will happen 2 different times in labor. It happens when the patient is about 6 centimeters, as that head is getting squeezed by the 6 centimeter open cervix. And it happens at the time when the bony pelvis, when the head is down by the pubic symphysis trying to come out. You get increase in intracranial pressure with the contraction that alters the blood flow. The vagal stimulation occurs. Whoop, down the heart rate goes. Pressure's relieved. Heart rate comes back up. Very normal, very expected, not worrisome at all. Just remember that pressure of the pelvic floor, and also at 6 centimeters, the cervix at 6 centimeters is the perfect size open to hit that head the same way as the pelvic floor does. So it happens and they get that deceleration. Early decels are uniform, they mirror the contraction, and they rarely drop below 100 beats per minute, and the variability stays healthy, moderate. And you see the head's getting here, that's the same area that gets hit when there's 6 centimeters. So that's where you get it from. The pressure, blood flow gets altered, stimulates the vagal nerve, decreases the heart rate, and recovery happens immediately. So this is a great picture of early decelerations. I'm really happy with this as a midwife and a labor and delivery nurse. But look here, you see this low point of the deceleration? That's called the nadir, N-A-D-I-R. The nadir of the deceleration is important because if the nadir of the deceleration is directly over the peak of the contraction, that is an early deceleration. Those are expected and healthy, normal. You see that? They resolve when the contraction's going away. Whoops. When the contraction goes away, the baseline returns to baseline. That's fine. That's healthy. So always look for where the nadir is in relation to the peak of the contraction. Now, late decelerations, at glance, they look similar to the earlies because they're that slow down and up, but they begin late after the contraction peaks. After it begins, often near the peak, that's when they start. The heart rate will return to baseline after the contraction ends. Late decelerations are a concern. They reflect impaired placental exchange or uteroplacental insufficiency. Realize that what is happening is that uterus is tightening, it squeezes the baby can tolerate it, and then boom, it can't. Okay, so we're going to see pictures of these in a moment. These require nursing interventions to improve placental blood flow and fetal oxygen supply. We'll learn what those are in a minute. Here is the mechanism of those lates. You have perhaps, this is one potential reason for them, is uterine hyperactivity or maternal hypotension or hypertension, anything that's going to decrease the oxygenation to the baby. These decrease the blood flow through that placenta, the infravillous spaces during contractions. It decreases the maternal oxygen transfer. Baby ends up hypoxic. They get a vagal response, which causes deceleration. Over time, it may develop into lactic acidosis, which becomes a real problem, like severe, okay? So we need to fix it at this level so we don't go over here to true placental dysfunction, which, boom, we're into severe compromise, all right? So in summary, uteroplacental insufficiency causes decreased blood flow, which causes fetal compromise. The characteristics, they are uniform, just like the earlies are. They begin at the peak of the contraction. They may or may not be repetitive. They can just happen once in a while. They're still a late. They rarely will drop below 100 beats a minute, and they do indicate hypoxia. The treatment for these is to increase oxygenation to the mom, however you have to do that. The nursing actions that you would take, well, let's first look at these, and then we'll talk about the nursing actions. Again, first of all, look for the nadir of the decel, and then go straight down. Oh, it is not over the peak, right? It happened late. So that's a late. This one, Oops, this is so hard to draw straight. Straight down. It happened late. So these are lates, okay? They look like earlies in that they're symmetrical and they go smooth and up, but they're late because they occur late in that. And this is an evidence that the placenta needs more oxygen, more blood, more fluid, more something. These, what kind of deceleration would you declare these to be? It's hard to tell. Yeah, I'm thinking that might be the bit. We need to adjust that TOCO. I can't tell where the contraction is. So we can't really tell. The third type of deceleration we're going to talk about are variable decelerations, and these are direct cause of cord compression. Think of a kinked cord, you're going to get a deceleration, all right? Because if the cord kinks, the blood flow immediately decreases. It's not slow like late decelerations. It immediately stops. Think of the water hose. If you were to kink the water hose, are you going to have a slow stop of water or a fast? Fast. It's going to immediately stop running through. Same with cord compression. If you kink it, the blood stops going through there. So you're going to get a very quick deceleration. They're not going to be that smooth low one, like the lates that take a minute. They're going to be quick down, like kink the cord. All right. They happen, but usually with contractions, they can happen in between as a result of the baby kicking its own cord. But these variable decelerations are either V, U, or W shaped. The fall and rise in rate is abrupt. These also require nursing interventions. A common cause is ruptured membranes. If you're sitting out the nurse's station and all of a sudden you start seeing deeks, oh boy, let me go check her. Maybe her water broke, because the water breaking, remember we said in a different, in the interpartum slides, is water breaking, the cord can prolapse and it's going to sit on its cord and you're going to get the result of cord compression as variable decelerations. So what is the treatment for variable decelerations? Get the baby off the cord, right? And we do that by changing maternal position. Turn her this way, turn her that way. This is the mechanism of the variable decelerations. You have that transitory umbilical cord compression. It collapses the vein, produces hypovolemia of the baby, and a transient acceleration, and then occlusion, and we get a drop of blood flow. Vagal nerve stimulates, heart rate goes down. If it's prolonged too much, it produces hypoxemia or hypoxia. Again, transient decrease related to compression of the umbilical cord. The characteristics are that variable shape, V or W, abrupt onset, and abrupt resolution. Bam, up, down. That's kind of high, up, down. It's variable in depth, greater than 15 beats a minute. It lasts greater than 15 seconds and less than 2 minutes in duration, and the fetal consequences are cord. So what do? We start flipping mom side to side to side to get the baby off the cord. Look at these. These are really obviously W's, right? See how quickly down and up? You see how they're different than the other types of decelerations? I showed you earlier this is the uterus. I showed you earlier this type of what you might see. And do you remember what that is? What does that indicate? What's happening with the mom? She's pushing. Relax. Push, relax. Push, relax. And so the baby is responding with pushing by getting squeezed. This is not abnormal. Okay, we're going to see these frequently at the end of labor as the head gets pushed and mom's pushing really well. So if delivery is fairly imminent, we don't worry about these. These are very normal at this point in labor. We don't ignore them, but we don't have to do anything when she's pushing, as they're obviously directly result of her pushing and increasing that pressure really high. More variables. Okay, here's the sudden drop. This is the U-shaped one over here. It's a sudden drop, but it goes up quick. Well, that's different than your late, which is slow to go down and slow to get up. It's a sudden U. This is severe. You see it drop suddenly, but then, whoa, it just kind of climbs up. That's a severe variable. These are the pushing ones. No big deal. Okay. Over here, she's pushing as well. She's getting variables. These down here, she's not pushing and she's getting variables. These actually look like shark fins. You got to really watch her. Now she starts to push. All right, it says pushing right there. So yeah, she was getting ready to push, so that is normal. And then down here, I can't tell what she's doing with her contractions, so these I'm not happy with. Look at, they go all the way down to almost 60. And look at the other part. What do you see minimal of? Variability. All right. That minimal variability and these long, slow recoveries and these little, this is a bad thing. This is bad. This baby needs to be delivered. Oh, look, it says right here, patient being prepped for surgery. Hooray! So. Then we have prolonged decelerations. They go down and it lasts a couple minutes. This is continuation here and it finally goes up. But look at the variability. It's all right. It comes back okay. This is worthy of watching. How often are her contractions? This may be the problem. She could be contracting too often. We might want to slow down the contractions to prevent this prolonged deceleration stuff from happening again. The prolonged decelerations can be caused by any of these here. I'm not going to go into this one much. I do want you to know it's another type of deceleration because I said there are only 3 and this is a 4th. The ones I want you to know are the earlies, the lates, and the variables. And then the sinusoidal heart rate pattern we mentioned earlier. If you want to refer to this, I'm not going to go through this, but these are some reasons you may get that, and a lot of them are fetal anomalies, or it can be medications. Pseudosinusoidal is the fetal sleep cycles, thumb sucking or rhythmic movements. They're short duration. Mom getting opioids will potentially cause what's called a fake sinusoidal pattern. All right, what's going on here? This is artifact. This is a loose wire. Don't panic. This just needs to have somebody go in and put a new one on. That's just loose wire. Artifact. Scary, unless you know it's just machine artifact. All right, so this is a summary of decelerations. The head compression, the earlies. The lates occur late, and then the variables. Now, we did not talk specifically about how to deal with these late decelerations, and it is vital that you know this information. So we're going to talk about it now. Whenever we have those late decelerations, remember they are due to uteroplacental insufficiency. It's not a simple cord, it's not a simple head, it's the placenta is not getting enough blood between mama to the baby, all right? We need to increase the amount of blood to the baby as fast as we possibly, oxygen to the baby as quickly as we can. So we want to put oxygen on the mom. We want to increase her IV fluids to have more fluid going through her system and delivering more blood to the baby. We want to change her position maybe. Sometimes they'll do better on their one side over the other, and for sure make sure she's not on her back. So those are all things we're going to do if we get these late decelerations. Put oxygen on, increase the IV fluid, and then make sure that these contractions are not too close together, because if that is happening, then that may be the cause of this insufficiency because it just can't handle it. So we need to space these contractions back out by either turning the Pitocin off, or if it's mom's normal body doing it all by itself, we may need to consider getting terbutaline would be the drug of choice to stop or slow down these contractions to let the baby have recovery time while we figure out what's going on. So just understand the difference. Is it going to help, like for this cord compression. The problem is the cord's tight. Is it going to help to give this mama oxygen? No, that's not the problem. She has enough oxygen. We just need to get the baby off the cord. So that's when we start flipping the mom back and forth. Okay, so if there's a question that says, what do you do for a variable deceleration? You do not select give her oxygen. That's not the problem. The correct answer is get the baby off the cord, flip the mom. If you have a situation where there's a late deceleration, flipping the mom back and forth is not likely to help too much. I mean, it is something we can try, but the important measures are give oxygen, increase IV fluid, and make sure her contractions are not tachysystole, too many. Okay? So just understand the causation of each and then know how to fix that causation. Non-reassuring patterns, there's tachycardia, bradycardia, decreased or absent variability, and late decelerations. So we have covered all those. The variable decelerations that persistently fall to less than 60 beats a minute for longer than 60 seconds aren't a problem. Remember, I showed you that one strip that I was not happy, and yes, they did take her they prepped her for surgery, and that's because it fell less than 60 beats a minute. Those prolonged decelerations, if they recur, if they happen one time and we've given the oxygen and turned the mom and done the IV fluids and they don't happen again, we don't get panicky about that. But if they persist, then we have to, of course, notify physician and perhaps get some ready to go to OR. And then the hypertonic, too many uterine contractions. This is a great way to remember what to do. I want you to write this down, memorize this, make this be your way to understand what is going on. If you see a variable deceleration, it's a cord compression. Remember, veal chop. Variable is a cord. Early is the head. Accels are okay, and lates are placenta. Veal chop. If you remember that, and you remember the characteristics as we just went through them, you'll be able to get those right, and then know what to do. What do you do with a variable? Turn the mom. If she's pushing, keep pushing, but if she's not pushing, let's rotate mom to try to get the baby off the cord. If you get earlies, what are you going to do? Document. Document, because it's fine. She's probably going to push soon. Accelerations, what are you going to do? Document. Lates, what are you going to do? Oxygen, IV fluids, slow down the pitch, slow down the contractions if you need to, and position change won't hurt. That's not the first thing you do. Causes of fetal tachycardia. Really, it's the same as what causes it in us, in maternals, in adults. The fever, infection, dehydration, hyperthyroid, drug abuse, and medications. All those that happen in mom can happen in the baby. Fetus, the fetal causations can be fetal anemia, heart failure, hypoxia, infection, and tachyarrhythmia. So anything that affects us will affect that fetus. The causes of fetal bradycardia. Heart rate dropping can be uterine rupture, placenta came off of there, mom's got low blood pressure or extremely high blood pressure. Medications, blood sugar, she's cold, fetal arrhythmias, rapid descent. Rapid descent can happen and like whoop, and you hope that the baby just gets delivered really fast. So just know that whatever events are happening to the mom will affect the fetus, and probably you can figure out if they're going to go up or down based on that. Prolonged bradycardia must always be evaluated for possibility of being the maternal heart rate and not the fetus. It is possible to be, on the external especially, to be picking up mama instead of baby. So if you have a fetal heart rate of 80 or 90 or even 100, make sure it's not the mom, because that'll put you into a panic you don't need to be in. Internal monitors, the internal scalp electrode, weirdly can also sometimes pick up the maternal heart rate instead of the baby, and that's if it's loosely applied, if it's coming loose off the fetal scalp. So if you get an 80 on an internal, it's probably the baby, but double check by listening, doing a maternal pulse. Okay? When responding to a non-reassuring fetal heart rate pattern, it's critical to remember how to identify the cause, know the veal chop, what's the problem, because if you don't have the right deceleration things to fix it, you're not going to fix it. So evaluate the cause, the maternal blood vital signs, and if there's a prolapsed cord causing that variable deceleration, right? Stop the oxytocin if she's got tachysystole, or if you just need to give that baby time to recover while we improve the heart rate, that is a perfectly fine thing to do. And make sure she's not on her back, okay? Increase the IV fluids, give oxygen, initiate the monitoring if not already in place. Notify the physician or midwife and prepare for imminent delivery for these non-reassuring heart rate patterns. Okay, so these are some non-reassuring heart rate patterns. So let's look at them to find out what is non-reassuring about them. You should be able to kind of see it yourself a little bit. We've already seen this one. We have very little variability here, kind of minimal, but then the big dip and the up, quick up. This is a variable deceleration, remember, and it goes down quick, down and then up, comes up quickly. So the concerning part is that it goes down to 60. Variables should not go that low. This is the one we saw before they were prepping her for delivery. Okay, so down here, what do you see? What is the baseline? Looks like 150 if I'm reading my numbers right. Yeah, that's 150 there. And is there much change in that baseline? Is it pretty straight across? It's pretty minimal variability. It's not totally flat, but it's definitely minimal. So then on that minimal variability, you add a 1-2 minute long contraction. That's deceleration. So we've got minimal variability and then a 2-minute deceleration. That is non-reassuring. What would we do for this patient right here? If you said give her oxygen, increase her IV fluids, and I don't think she's having contractions, and then turning her, making sure she's not on her back, you would be correct. Down here, oh my, what is this variability down here? What's the baseline? 130, the baseline is okay, but there's no variability. That's a ruler. That's like flat. No variability. Contractions doesn't even matter. We don't have them. If she had a contraction, I can guarantee you this thing would go down and not come back up. That baby has no reserve. Clarification of these non-reassuring patterns. What we do as nurses, we will put our finger in and just do some scalp stim. We push the head, see if we can get that heartbeat to elevate, because when we do some scalp stimulation, the heart rate should accelerate. Okay, that just tells us that it's able to neurologically respond. If it can't, there could be a severe problem. Here's the result of scalp stimulation. Boom, goes up quick. Stimulated here. It says, what are you doing to me? That's good. Good response. ACOG, American College of OBGYN, has come up with a nomenclature for the categories of baseline patterns. Category 1, 2, and 3. And that's to make it easier for a nurse over the telephone to deliver to a physician the severity or non-severity of a pattern. Category 1, we hear category 1 on the phone, we're happy. Normal heart rate, good rhythm, good, there will be accelerations, no decels, we've got a good pattern. Category 1, I can still sleep. Category 2, that's where we're starting to get a minimal or marked or absent variability, so that's starting to change a little. There might be some decelerations, and we start getting tachy or bradycardia. And so we're like, this is a category 2. We do not yet need to intervene with the labor. We don't need to take her for OR, but we need to do some actions. Oxygen, increase fluid, watch those contraction patterns, make sure we're not overstimulating, overstressing the baby. So category 2, we need to start doing some nursing actions. And then category 3, no variability and late recurrent variables and Brady. These babies need to be C-sectioned out. So if a doctor was at home and you said, I got a category 3, he better get on and rush in and say, get that OR ready and be ready to deliver that baby. Because if we have no variability and decels, I can tell you this flat line of variability and these decels, eventually it's going to go like this. It does not have reserve. And then sinusoidal, and those are hard to determine, sinusoidal versus pseudosinusoidal, but these babies generally will be known ahead of time if they've had fetal surveillance with ultrasounds prenatally, and so we would know to interrupt that pregnancy too and get that baby delivered. Amnio infusions, I don't know if they're doing these too much anymore. They used to do these a lot to try to increase the amount of amniotic fluid to prevent cord compression. All right, so if you've got low fluid and that cord is getting tightened, if they can put more fluid in there, and they do it with a Foley catheter thing, believe it or not, they put the tube in and they put in warm saline into the uterine cavity. And now understand, these will be ruptured membrane, people. Can't do it if they're not ruptured. So if we have some variable decelerations due to cord compression, then we're going to they would put fluid in there to decrease the pressure on the cord, as well as, there's another reason to do that, decrease the thickness of meconium if there's meconium fluid really thick. Understand with meconium, remember that's the baby had a bowel movement due to low oxygenation episode. If that low oxygenation episode happened today, say, this day that she's in labor, it's going to be thick. Not all meconium fluid is thick. You will sometimes get a light meconium, and what that means is this low oxygen incident happened days ago, and over the days it's had time to replenish, and clear out some of that thick meconium naturally, and so it will become thinned out. So if you see thin meconium, it means that there was a prior issue, not a current issue. It's the thick meconium that's like, whoa, this has not had time to the baby peeing to add more pee to the fluid to make it cleared out. It doesn't have the time to do that. So an amnio infusion is a way to help decrease the thickness of meconium. But they're not doing this much anymore, I don't think. This is just for your viewing pleasure, some common abbreviations. Those of you who are interested in labor and delivery will maybe want to take note of these. You're not going to be tested on them as far as I know. Same here. And then develop a pattern to your report of your fetal heart rate tracing. If you're calling a physician in the middle of the night, you want to be straightforward and succinct. And we teach you the S-bar, so it's a situation in the background in your assessment and your recommendation. So first off, I would start with contractions. She's contracting every 2 to 3 minutes. They're adequate. They're lasting, about 50 seconds, and she's doing fine. Okay, you don't have to give every minute detail unless there's a problem. The second part would be the heart rate. The baby's heart rate's about 150, got good variability, and she's having acceleration, so we're good. Or she's having variables, but it's only when she pushes. Or she started having late decelerations about 30 minutes ago, and I've done the IV and the oxygen, and they've resolved, but I just want to let you know she had them. Okay, and then the category assignment. She was a category 2, but right now at the present she's a category 1. I got good variability back, etc. So develop that pattern, because that's what the OB is going to need to hear spelled out in a systematic way. Okay, so let's give a physician report on this tracing, starting with the contractions. How often is she contracting? How long are they lasting? And I don't know if we'll say it's an external, so I won't ask you about intensity. So how often is she contracting? Okay, let me show you what I would get. If you do peak to peak, you got one here and one here. So peak to peak would be 1, 2, 3 minutes, 3.5. This peak to this peak is 1, 2, 3 minutes. So 3 to 3.5 minutes. Okay? Or if we did beginning to beginning, let's do that one. 1, 2, 3.5. And then from beginning to beginning here would be 1, 2.5. 1, 2, 3 actually. I'm sorry. 1, 2, 3. So either way you get the 3 minutes. Okay. How long are they lasting? Ten, 20, 30, 40, 50, 60 seconds. 10, 20, 30, 40, 50, 60, 70, 60 to 70 seconds. Okay? Is this an adequate labor pattern? Yes, every 2 to 3 minutes, lasting about 60 seconds. Now tell me about the baby. What's the baseline? You said 130. I would agree with you. What is the variability of the fetal heart rate? The wiggliness of the line. Absent, minimal, moderate, or marked? Remember the beats per minute. This is moderate, nicely moderate. It's not little and it's not straight. It's a moderate, okay? And it's not marked because you can determine a baseline. Are there any baseline changes, i.e. accelerations or any decelerations? And remember the 15 by 15 rule for an acceleration. This looks like one, is it? Is it the 15 by 15? It goes from that baseline of 130 up to 150, so yeah, that's 20. And then it lasts 10, 20, 30 seconds. So yeah, that's a good acceleration. So our report to the physician would be, she's contracting every 3 minutes, lasting about a minute long, and the heart rate baseline is 130 with moderate variability, and she's having some accelerations. I'm thinking she might benefit from Pitocin because we could get, you know, those contractions closer together, but baby looks good. Okay. It's another exercise in evaluating the pattern and the tracing. So I'm going to have you first talk about the contractions, write down on a piece of paper how often they're occurring and how long they're lasting. All right, I'm going to do peak to peak. There's a peak, and here's a peak, and here's a peak, and here's a peak. So I'm going to say this is 1, 2, almost 3 minutes, 2.5, 1, 2 minutes, 1, 2 minutes. So about 2 minutes, 2 to 3 minutes, 2 to 2.5. Okay? Did you get the same thing if you did beginning to beginning? You should. How long are these lasting? Ten, 20, 30, 40 seconds there. 10, 20, 30, 40, 50, 60 seconds there. So they're about every 2 to 3 minutes, lasting about a minute. Okay. Now tell me about the heart rate. What's your baseline? (150). What's your variability? Wiggliness? I'm going to say kind of minimal. 3 to 5 beats per minute changes. Any baseline changes? Yeah, right there. What is that? What's the shape of it? Is it smooth like the earlies and lates, or is it more sharply down and up, fast down and quick resolve like variables? If you said variable, you'd be correct, and it's happening with a contraction because it goes down fast and comes up fast. All right, chord, right? And let's try this one down here. What is the contraction pattern? How often? This one I'm going to go beginning a contraction and 1, 2, and then it's 1, 2, 3. And then it's 1, 2 and a half. So 2 to 3. How long are they lasting? About 50 seconds. Okay, so they're about every 2 to 3 minutes, lasting about 50 seconds. And then tell me about the fetus. Baseline? About 150, right? Variability? Wiggliness? Kind of minimal. See along in here, it's not moving, not too big change. This here, over here, looks better. Then baseline changes. What's going on? Whooping up. So what goes whooping up? Down, fast, up. Those are those variables, remember. Variable decels. Okay? Did you get that? If not, go back and review. And the final one, early decelerations. You see them happening right above the nadir is above the peak. They're round and smooth, so those are earlies. Yeah, would you have recognized that? This one over here looks a little more variable because it goes down kind of fast. So you could have a combination of them. I mean, you can have a combination. I'm not just making that up. Because if she's getting pushing and also the chords there, you're going to get 2 types of deceleration. So, well, I hope this has helped you understand monitoring a bit. I know it's a lot of information. I'm glad it's on recording so that you can maybe review and look through it. What's important to know is identifying the different types of patterns and what the nurse's actions need to be to improve the pattern or support an already good pattern. When do you not need to do something other than document? So it's good to understand both. So thanks, and I hope this helps you.